Thank you all for coming. And yes, thank you for the HRC for their support, which has been fantastic in terms of getting some of this theory into practice. Let's take a moment or two to figure out the technology. Okay. So for those who don't know me, my name's Simon Thronley. Malolele, kia ora. I'm just going to, whoops, wrong one. Just going to give you a little bit of the backstory to how we got going in this area. Okay, all right. So why do I think scabies is the cause of rheumatic heart disease? It's I know that in New Zealand, generally the paradigm is related to Group A strep being the primary cause, and we certainly think that Group A strep is a big part of rheumatic heart disease, but we think there's a missing step, which is an integrated part of what is thought to cause rheumatic fever in many different parts of the world, but seems to be not so much part of the agenda in New Zealand. Let's just see if I can get things going. So just an overview of the talk in the next half an hour or so. Look at some of the traditional theory of rheumatic heart disease, some of the reasons why I became sceptical of the traditional cause, why I think scabies is likely to be an alternative hypothesis, promising alternative hypothesis, some of the tricky things, thorny issues with scabies and rheumatic heart disease. Much of it relates to the diagnosis of scabies, which is something that I've had to learn about in the last 4 to 5 years. And scabies certainly can be very subtle. And we'll review some of the evidence. Sep Torshi, PhD student who's just recently joined us from India, will be going over after lunch some of the really interesting results of the work that we've been doing in Tonga, which has been a lot of fun. And Cello, who's joined us from Brisbane, has been a really critical part of our research, because I think I'll show you that diagnosing scabies can be very subjective, and that's one of the issues that I think has muddied the waters with rheumatic fever and scabies. And you can get two clinicians in the same room looking at the same child and completely disagreeing over the diagnosis, and that was our first little foray into scabies research. In fact, we had 3 clinicians, and the agreement between their diagnoses was less than expected by chance. So Cello has been developing a PCR test that provides some objectivity in terms of the diagnosis, and I think that's a critical part of the puzzle. But I thought I'd, as Viliami mentioned, taking a biopsy in Tonga, putting it in his shirt pocket, having scabies in the family, is a great way of learning about the diagnosis of scabies, and that was part of the thing that I knew nothing about scabies at medical school. I think it was a hole in the curriculum. I remember as Medreg being told, oh yes, I think this patient has scabies. One of the registrars was a GP trainee, so it was sort of, you can look after that, it's not really that important. And I was kind of mystified, and then between me and my wife, I think we ended up getting this funny itchy rash that seemed to circulate around the family about 7 or 8 times, and it seemed to have none of the classic textbook signs of scabies, but it certainly got better with permethrin treatment, and eventually we actually, one of our daughters our daughter got side effects with permethrin, and we asked for ivermectin. That was even more effective. And often I would take my daughter, who might be the first case, to the GP and say, Lauren, please just explain to the GP what's happening. And she would say, oh yes, I've got these little spots that are itchy. And the GP would say, oh, these are insect bites. I'd say, okay, yeah, it could be insect bites, but I actually think it's possibly scabies, and would like some treatment. And often we would go away, get some treatment, and it'd be gone within a day. And this has happened over and over, and so I could see that there was a lot more scabies in the community than we appreciated. And then looking at being a public health physician in counties, being tasked with the idea of trying to prevent hospital admissions, seeing a lot of bacterial skin infection, that led me down the path to look at scabies. So let's just keep going. So what was I taught at medical school? What do I know about rheumatic fever before I started looking at scabies? It's almost exclusively a disease of Māori and Pacific children, certainly linked to streptococcal sore throat. We're not questioning that. It's clustered in families associated with overcrowding and poverty. Many cases also have bacterial skin infection. And the diagnosis is based on evidence of strep infection along with clinical features. And this is Frank Netta. For those of you who've been through medical school, just about everyone leaves with Frank Netta's anatomy classic textbook, full of these beautiful drawings which sort of encapsulate the collected wisdom of the medical world. And this is rheumatic fever via Frank Netta. So throat infection, hemolytic streptococci, leading to cross-reactivity with certain tissues in the body, and symptoms such as migratory polyarthritis, carditis, skin involvement, sometimes neurological involvement. And this is the New Zealand version, started with sore throat. Just some more background here. For epidemiologists, rheumatic fever is an interesting disease because, unlike many diseases which affect almost all ethnic groups in New Zealand, many of them higher rates for Pacific and Māori, rheumatic fever is unusual because there's almost no rheumatic fever in other ethnic groups. It's almost exclusively a disease of Māori and Pacific children. So you can see Māori, Pacific, and other ethnic groups. And you could say, isn't that the case for every disease? Well, here's an example of another disease that I've just drawn out just because it happens to be in something that ESR reports on. Salmonellosis, we don't see anything like the same pattern. And another curious thing is that Group A strep, which we've been really trying to hammer in New Zealand, if you look at the prevalence of Group A strep, you see that the prevalence is actually here, it's slightly higher in high-income countries than low-income countries, which is strange. Generally, rheumatic fever is only a disease of low-income countries. Some countries such as the UK, US, many parts of Europe, rheumatic fever is a very rare disease. Another thing that got me thinking was the school program based on early treatment of sore throats. So the hypothesis was that the reason why rheumatic fever was happening was that kids weren't able to get antibiotic treatment for their sore strep throat early enough. And so the idea was to go around classrooms and treat sore throats early. I happened to be working at public health at the time and providing these reports about rheumatic fever incidence, which is a notifiable disease, and really being disappointed not to see a more dramatic reduction. So here we've got, you can kind of see that there might be a slight reduction in the Māori rate here, the lower line, but certainly no reduction in the Pacific rate. Okay, sorry. Okay, so what is unexplained by the traditional bacteria-centric theory? So here's some research from the Otago group, and they've done some great research, I think. And it's interesting to look at, so the risk of, so the prevalence of Group A strep positive throat swabs from community laboratories. And you see very little difference by ethnicity for throat swabs. It's a bit unusual. Certainly doesn't match what we'd expect to see with rheumatic heart disease. We do see a difference with skin swabs, about a twofold difference. We also see that the risk of rheumatic heart disease rises after a Group A swab, and also after a Group A skin swab. But there's some things which are unexplained. So, for example, so all of these people in this cohort have had a positive Group A swab. Here we're comparing New Zealand, European and other versus Māori and Pacific. There's a tenfold difference in the incidence of rheumatic fever. The question is why? After a Group A skin swab by ethnicity, the rate of rheumatic fever is relatively high in Māori and Pacific compared to European. In fact, none of the cases had, none of the Group A positive skin swabs had developed rheumatic fever. So a massive difference, and the question is why? And so I think that these results suggest the presence of an unknown second factor, and I think we've identified the second factor. I have to acknowledge we went in some directions that I think were unhelpful. We thought it could be the teeth. We noticed major differences in terms of prevalence of rotten teeth between ethnicity by deprivation, seemed to fit some of the risk factor profiles that we were seeing with rheumatic fever. And we published some studies related to that, even got a study in a very good journal, and we did a cohort study comparing kids with with lots of rotten teeth versus less rotten teeth, and saw a difference in terms of incidence of rheumatic fever, but it was a small difference. And the other thing that was surprising was it didn't seem to mediate that relationship between ethnicity and rheumatic fever that we would expect to see if it was a true cause. So let's just gather some thoughts up. What are some chinks in the Group A strep causes rheumatic fever theory? Many cases of rheumatic fever don't have a sore throat. In fact, in Australia, it's commonly known that sore throat is very rare in cases. It's more common in New Zealand cases. Sore throat is not part of the diagnostic criteria. I can't see a positive statistical relationship between evidence of group A strep and traditional risk factors of rheumatic fever, so the difference in terms of wealth, high income, low income countries, is not explained by group A strep prevalence. The school program based on treating sore throats resulted in no difference effectively in early treatment versus usual care. And part of the work that I did got me involved with some Australian paediatricians, and just looking at some of their publications, they had, if you look at the right side of this diagram, it's largely consistent with the New Zealand model of rheumatic fever causation. However, there's also a left side which talks about scabies. Scabies leading up to the strep and the soft tissue infection and post-strep complications. So let's just think about what's the evidence that scabies might be a cause. What's part of the biology? Well, scabies is a microscopic mite, about half the size of a pinhead, and burrows into the superficial layers of the skin, lays eggs. Also, some of the work that is happening in Cello's part of the world shows that it's not just making physical holes in the skin, and that's the only immune issue that it's posing. It's also, scabies secretes various proteins which interfere with innate immunity. It's not my area, but it certainly seems to be part of the picture and interferes with complement and various other immune pathways. One of the issues that we had in the early days was, look, isn't this just a trivial difference? Well, yes and no. I think one leads to improved diagnosis and treatment of scabies, whereas the other leads to use of antibiotics, development of strep vaccines. So there is a difference, I think, and it's an important one. So what, in terms of, so looking at group A strep carriage wasn't convincing in terms of the epidemiology. What about scabies? Where is there a lot of scabies in the world? Well, in the Pacific, in the Aboriginal community in Australia, parts of Africa, South America, Central America. Seems to be similar parts of the world affected by acute rheumatic fever. And Septorshi's done some work where we simply looked for studies that reported the prevalence of scabies and looked for studies that reported the prevalence of rheumatic heart disease by echo, and you see a surprisingly strong relationship. There's about a 10-fold difference in prevalence in terms of scabies, higher prevalence than rheumatic heart disease on echo. But if you look at the line of best fit, what you see is that for every 10% increase in scabies prevalence, you get a 10% increase in rheumatic fever prevalence. Curiously, if you do a literature review, you see some evidence that scabies may be causing some of these historic outbreaks of rheumatic heart disease. So here's a little quote I thought I'd just read out. 93 patients with acute rheumatic fever and 195 patients with acute glomerulonephritis, so it's a kidney issue, were observed in Trinidad during an outbreak of scabies with a high incidence of secondary streptococcal infection. So this is a paper where there's been an outbreak of scabies. It's been followed by an outbreak of rheumatic fever and post-streptococcal glomerulonephritis. And this is in fact in the abstract. If you read the body of the paper, it's all about strep and treating strep. So even though they say that up front, it's kind of just cast aside, put in the background. So one of the first studies I did, which convinced me that scabies was likely to be an issue, not the ideal study I might add, but it was certainly something I could do with the data that I had at hand, was look at a cohort of kids who are seen in dental clinics and look for evidence of scabies in their hospital records. And for clinicians, I think you'll realise that scabies is often more commonly seen in primary care than it is in the hospital. So we've missed a lot of cases, but is there a connection here? So we looked at scabies before the dental exam, scabies after the dental exam, and incidence of rheumatic fever afterwards. And we saw a very, very strong association. So those with no evidence of scabies had a very low rate of rheumatic fever. Intermediate if they had scabies before their dental exam, and then after a very high rate. And actually looking into the case records, many of the cases of rheumatic fever were actually had scabies in their discharge summary, the same discharge summary. And so in contrast to what we saw with the rotten teeth, we saw a very strong association, so a 26-fold difference comparing scabies after to no scabies. And we also saw that once you put this scabies term in the model, that the very, very strong association that you see with ethnicity is attenuated, which suggests that scabies may be a mediator. Okay, so that was published, didn't get a lot of interest apart from in the Australian rheumatic fever community. So I thought, well, let's have a look at, people seem to be convinced by maps these days, let's have a look at maps and the association between where rheumatic fever cases are happening in Auckland and where scabies treatment is happening. And this is, again, this almost, once I produced the map, I almost fell off my chair. The association, the geographic association is very strong. The parts of Auckland that are where permethrin is being prescribed, the dark areas, happen to be South Auckland, West Auckland, GI, also very strongly associated with the addresses of rheumatic fever cases. And it's very clear that rates of permethrin prescribing are strongly associated with the proportion of Pacific people living in that neighbourhood. So here the area of the points represent a neighbourhood, very strong association. So I think the Pearson correlation coefficient here is about 0.9. In fact, it's interesting that just about all these factors, so socioeconomic status, proportion of Maori, proportion of Pacific living in a neighbourhood, are very strongly correlated. So there's the Pearson correlation coefficient. So untangling all this is tricky. But when we use a regression model, we see a very strong association with permethrin predicting the rate of rheumatic fever. Just another way of looking at the data, you can This is another talk in itself, but basically you can give a spreadsheet to a computer algorithm and ask it, based on patterns of conditional dependence between variables, how do you see the causal relationships? And the computer says permethrin prescribing associated with rheumatic fever, as ethnicity and deprivation is associated with permethrin, which is then associated with rheumatic fever. So, slightly troubling from all this, yes, is association between permethrin and rheumatic fever, is that the treatment doesn't seem to be preventing the disease, which is what we would be expecting if the treatment was effective. Okay, so that was interesting. The last scabies prevalence study that had been done in New Zealand was in the late 70s, about 40 years ago. So the next question was, how much scabies is there in New Zealand? And are we diagnosing scabies accurately? Impetigo was something that's recorded a lot in the medical literature in New Zealand. I noticed that almost exclusively the treatment is with antibiotics or topical antibiotics. However, in studies of the Pacific, you see a very strong association between scabies and impetigo. Almost all the cases here, so this is a diagram, numbers are proportional to the areas in each group, and they reported a relative risk of 56 for scabies leading to impetigo. And this is what it looks like in a diagram. Almost all the cases of scabies also have impetigo. So this is the last study that was done. So high rates in Māori and Pacific, about 20%. This was a survey of high school students, and Europeans you can see about 3%. This was the first study that Gerhard will discuss in more detail. We went to a childcare centre in the heart of Otara, but about 40% of the kids were on some form of treatment for their skin, usually an emollient, steroid, and just made no reference to the diagnosis, just asked a nurse, a GP and a dermatologist to give their assessment of the child's skin. And so the nurse diagnosed 20% with scabies, the GP another 20%, and the dermatologist said none of them had scabies. And when I asked what the criteria were, he said, I was looking for burrows and mites. So we showed some of the photos to an Australian scabies expert who said, it looks like scabies to me. I've just come back from the Solomon Islands, diagnosed 200 kids with scabies, not seen one burrow or one mite. So it struck me that the criteria for diagnosing scabies are extremely important. So the next step was to start looking at what are the criteria for diagnosis. And thankfully, a team in Melbourne and Australia and around the world had done a lot of work looking at trying to get some consensus on the diagnosis of scabies. And so there was a shift from looking for burrows and mites, which is really the territory of dermatologists and specialists, to looking for crops of papules, which we'll talk about later. So here's an example on the hand, here's an example on the foot. Here's a couple of early photos from our survey dermatologist thinking these may be burrows, which we completely missed. So we, cut a long story short, we did a survey in various childcare centres funded by the HRC looking for evidence of scabies using papules, which is suspected, or clinical scabies, which is a slightly different entity to what seems to be traditionally used, where many clinicians look for confirmed scabies. And we saw that there was, we also got Cello to give us a hand analysing some skin swabs. So this is something that's not available in New Zealand yet. We're hoping that that one day it will be available for clinicians. There's a laboratory interested in developing this. It's currently in development. So you can see here, this is the total population, the outer square, and so the grey have the clinical signs of scabies, so the papules, crops of papules on the arms and legs. The smaller green square formally meet the criteria, and you can see also that the yellow here is PCR positive cases, so some meet the formal criteria, some don't. And then you see a whole bunch of kids who are on topical treatment for other diseases, some of them other skin diseases, mainly eczema, urticaria. They're on calamine lotion, topical antihistamine, steroids. We had a few dramatic cases of kids treated with eczema that had PCR positive scabies. We'll cut a long story short, but we saw a reasonably strong association in the Tongan study, not statistically significant. This was in the first study, but if you did a population attributable risk calculation, assuming that this is a causal association, it accounted for about 40% of rheumatic fever cases. So this was looking at kids, as Gerhard mentioned, who are having an echo for rheumatic heart disease screening. We looked for clinical scabies. So just putting it all together, I know, great for morning tea. Is there a causal relationship? Well, the usual way epidemiologists try and resolve this is to use the Bradford-Hill criteria, and many of them, I think, are met for scabies and rheumatic fever. There's a strong association, strongest I've seen in the cohort studies. Septushi will show you some fairly strong associations later in the day. Is there a dose response? Yes, I think there is. Is it biologically plausible? Yes, there's a link between scabies, strep, group A strep, complement, rheumatic fever. Is it coherent? It's coherent to me. There's a high prevalence in Australian Aboriginal groups. There's a high prevalence of rheumatic fever in those groups as well. Also in the Pacific, high prevalence of scabies, high prevalence of rheumatic fever. Is it consistent? Yes, we can see consistent studies from the ecological study that we showed. High prevalence of scabies, high prevalence of rheumatic fever. Temporality, we had a cohort study that separated the exposure and the outcome. Our Tongan studies are cross-sectional, so they don't have that. Enology, well, it's many people are not aware of it, but it's kind of in the textbooks that scabies leads to post-streptococcal glomerulonephritis. What is post-streptococcal glomerulonephritis? It's like rheumatic fever of the kidney. It's an immune-mediated disease related to recent streptococcal infection, as the name implies. What are we missing? We're missing experimental evidence, and I think the Australian group, the World Scabies program, are currently doing some studies in Fiji looking at this very question. If you treat scabies well, do you reduce the prevalence or the incidence of rheumatic heart disease? So I thought just before we break, I better, obviously there's a bit of controversy in this area, and some studies don't show a convincing association between scabies and rheumatic fever. And why is that? So there's one study from the Otago group, for example, that actually does show quite a strong association between having scabies and developing rheumatic fever. Their odds ratio, adjusted odds ratio, is 6, very strong. But then they say that only a very small number of cases and controls in their study were diagnosed, had scabies, so it can't be a big player. Okay, well, let's just have a look at the details. How did they diagnose scabies in their study? They asked people, do you have scabies? In our surveys, when we asked people, did you have scabies, about 5% said yes. When we looked at their skin, we got a prevalence of between 20 and 30%. So again, it comes back to the definition, I think. A self-reported diagnosis of scabies is just not useful. If, as in our case, there's a tenfold difference, if we put that tenfold difference into the numbers, we actually get a population attributable fraction of about 40% for scabies. Another objection is, isn't scabies just about the determinants of health? It's not scabies, it's poverty, it's low income, low access to healthcare. That might be true, and scabies certainly is associated with poverty, low income, overcrowding, etc. But in South Auckland, I was part of the study, so there was a lot of work put into addressing overcrowding in Mangere Otara at that time. During that interval, rheumatic heart disease actually increased by 23%. So yes, it's associated. Do I believe it is a causal association? This intervention doesn't show that. In the Pacific, when scabies is treated well, they get commensurate reductions in prevalence of bacterial infection in the skin. Impetigo, cellulitis rates go right down. So without changes to housing conditions, socioeconomic conditions. So okay, so just to try and sum up, I think the scientific evidence that scabies causes acute rheumatic fever, rheumatic heart disease is more and more compelling, and I think Septorshi is going to give some more data along these lines, and I think the nice thing about scabies is that it's treatable and we can do something about it, and I think it offers a fresh approach to rheumatic fever prevention. So many people have helped along the way that I want to acknowledge, and this idea seems to be picking up some currency in the Pacific. So, and thank you very much for your time. Happy to take any questions.
I just wondered, because there was such a big drop in our during 2021-22, and that associated with the COVID pandemic measures, and the sort of theory around that is a reduction in gas transmission. Everybody thought, provisional hypothesis. How do you account for that in terms of your Scabies hypothesis? I mean, are you sort of saying that it's a secondary skin infection that is related to scabies that is the trigger?
Well,
Scabies itself?
I don't want to steal Sepp Torschi's thunder, but he will present some data which looks at, so got kids with scabies and skin infection, and actually the association was strongest with scabies and skin infection with the echo findings, not just scabies alone. So I think from that work we're thinking that it's scabies and the secondary infection which leads to rheumatic heart disease.
And just one other comment, I'm working on a study, and we haven't published it yet, but it's updating some of the rheumatic fever data, including the COVID period, and we do a different analysis from the Bennett one that you referred to here, compared to decades ago. But it looks like there was a significant reduction in ARF between 2015 and 2019 compared with 2000. So that's interesting. 2020 was quite an exceptional year. We don't really understand why. There's two things going on: lockdowns and a sharp rise in ARF in the first half of the year, and then it was 2023. It bounced back to pre-COVID kind of levels. So lots of things you don't fully understand over it.
Yeah, I mean, one possibility is that there wasn't a lot of travel at that time. We know that in the Pacific there's very high prevalence. So that's another possibility.
I understood with the sore throat program that a lot of nurses were also assessing and treating skin infection at the same time. You found no change in acute rheumatic fever prevalence related to that.
Yeah, well, that's an interesting. When I worked at counties and talked to the nurses about exactly what was happening there, they did say that there was a lot of scabies at the beginning, and then they didn't see a lot. And I think most of the treatment was antibiotic related. And when I tried to look for criteria for diagnosing scabies, there wasn't a protocol.
Basically treating skin infection with Tiger and... with antibiotics, yeah. So that was an aspect to it. So there wasn't a lot of, there was apparently some treatment for scabies initially, and then very little after that. And our prevalence study came in, that was well beyond that time, and we saw a lot of scabies in preschools and schools. So we don't think that it was effective. The scabies, at least, was effectively treated.
I just had a question. You had your diagram that showed direct and indirect action or determinants of rheumatic fever, and for Pacifica there was a direct connection from Pacifica to rheumatic fever, but from our view it was entirely mediated by the other things in the program.
Excuse me, Simon, what was the precedent? Because I didn't quite hear.
Oh, sorry. I think it was relating to this, which is a sort of, let's call it a learning Bayesian network analysis, where we look at basically the associations between different variables in the data set, and the computer draws a diagram. There's various different algorithms. I think, so here you're saying there's a direct association between Pacific and rheumatic fever, whereas Māori, it's mediated all through permethrin. I mean, this algorithm is based on statistical testing, so conditional dependence tests. So there's an error rate associated with it. So I wouldn't say it's completely, it's.
And does the permethrin pretty much map deprivation?
Isn't
it just a proxy for deprivation?
Well, that's the question, isn't it?
The map, it looks very much like the NZD map.
It does. In the regression model, we have deprivation here, and it doesn't explain, once we put permethrin in the model, it doesn't explain the prevalence of the incidence of rheumatic fever like permethrin. So it's actually...
But deprivation doesn't know that.
Yeah, deprivation doesn't know, but permethrin does. Permethrin is a very important term in the model.
So you're saying it's being prescribed appropriately?
We're saying we're saying that, there's certain assumptions here. That we're using permethrin as a marker for how much scabies is in that community, in that neighbourhood. It seems that it's not actually reducing the prevalence in that neighbourhood.
To treat a community properly, the WHO recommended there's a prevalence over 10%, you should do rheumatic administration. So that just indicates that there's a lot of scabies in the community. It's being treated, but whether prevalence is coming down significantly is not.
Simon, just a moment. I guess I'm concerned about medication is dispensed or diagnosis. Go back to how certain are you the diagnosis? When he pointed out already that with diagnostic criteria, not taught well in medical school, he experienced to recognize it. He pointed out that we were looking at the classic borrows, etc. But he's saying that papules are actually a little bit something that actually gets missed. So we're using like permethrin dispensation records and then implying that that's a level of scabies. Me is not going back, then that's in New Zealand, in our Auckland neighbourhoods. Well, how safe are you that it was actually scabies?
Yeah, well, I think that's a good point. I mean, we're using this as an indicator of how much scabies is in the community without actually getting our hands dirty and having a look, which we eventually did. But I guess the approach that in epidemiology we often use this, where we assume that there's a relationship between permethrin and scabies in the community, but it's measured with some form of error, which is likely to, if it's random, is likely to actually attenuate the association between scabies and rheumatic fever. So yes, I completely agree that permethrin is sometimes likely to be prescribed inappropriately, but it's an indication, and I think a useful indication, of how much scabies is thought to be in the community by primary care professionals who prescribe it. So good point. Okay, I think we'd better keep going. There's plenty of time for further discussion. How are you?